if we have a situation here where I'm compressing here and she's complaining it's going down her back, that's not the brachial plexus coming down the arm, right? So instead we have different nerves like the dorsal scapular nerve. So again, dorsal scapular nerve is going to pass under like levator scap and upper traps. It's going to get compressed between the two. So if we have someone who's a little bit stressed and kind of holds their shoulders like this the whole time, we compress these nerves and relax that. So when I squeeze in here, again, she shouldn't within 10 seconds or 20 seconds start saying it's going down my back. It means that we have, and if I'm a little bit pokey, Grace, do you mind? Is that a bit tender in there?
Yeah.
So if we're looking at dorsal scapular nerve, it's this beast. Comes down the back of the medial border of the scapula and it branches. So a lot of patients, when they're saying they have this horrible burny pain around here, the instinct is obviously, is it a rib, is it a joint? But sometimes we need to look a little bit higher and look at these nerve entrapment sites.
Yeah.
So we can have that all over the place. One of the reasons I love that diagram earlier with the occipital nerve is if a nerve goes upwards, so we compress somewhere and she says it's going up into my head, or maybe I compress around here and she says it goes up into her ear or up into her face, central pain sensation goes downwards. It just goes down through the dermatome. So if pain goes upwards, it almost certainly means you're hitting a peripheral nerve. Right. And luckily, peripheral nerves are pretty simple to treat. We find the entrapment site, and myofascial release works really well. So there's good research for looking at myofascial release with a median nerve at the elbow. So whether you're doing manipulation, triggering, myofascial work in particular seems to have good research for it. Whether you're using things like low-level laser to get it going. But anything you can do where we want to see pretty quickly that we compress it and that pain goes down.
Yeah. Are you a fan of laser?
Yeah, I have a low-level laser. It's a bit murky, the research on it, because there's it's like having pizza. There's so many different pizza types and there's so many different ways you can make a pizza that you really need to look at the research and say, does this device have the research backing it? And I think there's some great devices and there's some waste of time ones. Yeah. So,
could I, again, to interrupt before you go on, Lawrence has said this is about radiating pain. What about referred pain?
It's the same, to my mind. Yeah. Same thing. So referred, if I'm compressing a peripheral nerve, it's going to refer into that dermatome. So like with Grace here, we compress this nerve, it refers into its sensory distribution. But if someone has referred pain to their arm, that for me is that pain sensitization. You're getting that secondary pain sensitization, and that is the radicular pain. So when we see a patient, let's say she's got this C7 radiculopathy, if there's no sensory changes and there's no motor changes, no reflex changes, I think there's a very strong argument to say it's not a nerve compression radiculopathy, it's a pain sensitization, which is perhaps very good for the patient. It maybe doesn't make such a difference to them, but it does to us. And I think this is where you would have seen the research on MRIs, and there's a very poor correlation between what you see on an MRI and pain. Yeah. And I think that's where it comes from. So you have this, it's happening less and less now, luckily, but in the old days, you go in, you have an MRI, oh, it's a whopping great big disc, let's do all the operation. What do you mean your pain's worse? Well, the pain's worse because you already had this fire of pain, screaming pain, and then you went in and cut it. Basically tore my finger off, right? You took a system that was already super pain sensitive and just set it on fire. And so the patient comes out with more pain. So that whole failed back pain surgery syndrome. I read a study once, it said, when you look across, it was a meta-analysis, they said that a systematic review, sorry, it was 10 to 40% of patients going in for back pain surgery come out with the same or more pain than they went in with. That's probably because that pain sensitization is very active.